When I first started exploring this topic of gender pay gap, little did I know I would be in such a large amount of hot water. There appears to be a lot of strongly held opinions on each side. In the field of urology, about 8.8% of the urology workforce is female, and in the training programs, about 36% of the trainees are female. There appears to be a gap in the payment for male and female in urology. There's no one better to discuss this than the lead author of a recent article in Urology Practice, Dr. Amanda North. She's the clinical assistant professor in pediatric urology, and I'm going to mess this up, Motefiore Medical School. Motefiore Medical Center in New York. So I have her on the program, and we are going to talk about her findings and the apparent pay gap in urology and what are some of the things that we can do to try to mitigate this problem. So welcome to the program, Dr. North.
Thank you so much for having me. It's a really interesting topic to talk about.
Yeah, so I have to ask, what led you to explore this topic in the first place?
So I'm pretty lucky that I am both the chair of the AUA Workforce Work Group and I'm a voting member of the AUA Data Committee. And what that does is it gives me advance access to the AUA census data. And so I've been doing research from the AUA census data for a few years now. And we were at a data committee meeting and the chief statistician at the AUA, Raymond Fang, he's amazing, was presenting data on the pay gap between men and women. And I went up to the chair of the data committee and I said, "Hey, Dan, let's study this. Let's write this up. This is really interesting stuff." And so I was given an amazing opportunity to work with the data committee to come up with this paper that we published.
Okay, so let's talk about this urology practice paper. What are some of the key takeaway findings? And more importantly, I want to spend some time talking about what are some of the things that we can do to try to mitigate the gap.
Sure. So we use $350,000 as a cutoff because that's the median salary of a practicing urologist. And so we found that women were less likely than men to earn greater than $350,000. In a lot of ways, that's not surprising. Women urologists, as you said, are younger than male urologists. So when we look at the urology population over the age of 60, less than 1% are women. When we look at urologists under the age of 40, 22% are women. And so obviously when you're starting in practice, you don't make as much as when you're further along in practice. And so it's not surprising if you don't adjust for age that you're going to see a pay gap just because of years of experience. But there's a lot more to it than that. I think one of the things that we're finding as I've done a couple of projects looking at women in urology is that women urologists practice differently from men. And I think we really need to understand why that happens and whether it's women are choosing to practice differently, which is fine, or women are being sort of forced to practice differently, even if they don't want to. So when I say women are practicing differently, women are much more likely to be academic than men. So 40% of women urologists are in academic medicine, whereas only about a quarter of male urologists are in academic practice. We know academic practice doesn't pay as well as private practice, for example. And so that can explain some of the gender pay gap, is that women are making different career choices. The other interesting thing is that women in urology are far, far more likely to be employees rather than practice owners. Again, if you're getting a share of the practice profits, you're going to make more money than if you're just an employee. And so some of this may be, again, age related. So there's a trend in medicine in general away from private practice that we've seen as we look at the AUA census data over the years. There's been a huge trend towards more employed urologists, fewer private practice urologists in general. And that happened just as women were entering our field. So that explains some of it.
Now, let's talk about the academic. So the decision to be in academics is a personal decision. So I'm trying to tease out if there are any actual biases, actual misogyny going on, if that can be identified. First of all, having this discussion is always good, right?
Of course.
Identifying that there is a pay gap, and then finding the reasons why is, I think, even more important, because without knowing why, we can't address if there's an underlying problem, and if there is, how do we address it? The decision to enter academics is a personal decision, so I don't think there's much of an issue there. When it comes to being an employee, I personally know female urologists who are just starting private practice on their own, and one is actually just starting a solo practice, and the other one joined another urologist. So there are a lot of thriving female urologists in private practice. And I'm wondering if the decision to join, to be an employee, is there a gender bias or some sort of a external force that is causing that to happen, or is that also a personal decision?
That's very hard to say. We know when we asked people about private practice that women were more likely to feel nervous about the business aspects of running a practice than men were. That's in one of the AUA census. I can't remember if it was 2018 or 2019. So women were more hesitant to be sort of business managers of a practice, for example.
So how do we bridge that gap? That's what I want to know. How do we bridge that gap?
Well, I think mentorship really is part of what we need to do. I think I'm obviously in academic practice, and I chose to do pediatrics, which tends to go to academic practice. There are private practice pediatric urology groups, but I always wanted to be academic. I love teaching. I love residents. I love being in that, I wanted to work in it with an underserved patient population. I work in the Bronx. It's perfect for everything I wanted. And, and some people think that women feel more comfortable going into academic medicine because that's where they've had mentorship, right? There's a very high percentage of practices in the US that have 0 women urologists as part of the practice. So that's still happening. But a very high percentage of practices say they're actively recruiting women into their practice. So I don't know what if it is gender bias versus lack of availability still.
Yeah, I mean, there's a national shortage of urologists. To find a female urologist, that's even more difficult, right? I mean, 8.8% of practicing urologists, only 8.8% are female. Thankfully, a lot more are in the pipeline being trained. And you had mentioned in a previous interview, just slightly over 50% of medical students are currently female. So that's definitely changing the disproportionate number of male versus female when it comes to physicians. So hopefully that'll bring about some changes. I am just perplexed by, how do we fix that potential fear of a female running a practice or owning a practice? As you know, I run the Thriving Urology Practice Facebook group. It's on Facebook. It's free, and it's only for urology practices in the United States. And my goal is to crowdsource practice management solutions to make every urology practice thrive. Male, female, transgender, I don't care. So, I'm trying to figure out ways to
religions, yeah.
I'm trying to find ways to level that any disparity to make sure everybody does well. And part of that reason is slightly selfish, because I already know that there's a shortage of urologists in the United States. I'm getting older. I'm turning 55 this year. So I need urologists to be around for myself, and of course for everybody else. I mean, there are only 12,000 of us in the United States. There are not enough urologists to serve everybody. And
especially in rural areas.
Yes. Oh, definitely. And thank goodness.
And women are much less likely to work in rural areas. So it makes it even harder. As we increase the percentage of women, we have to find ways to encourage women to work in all practice settings, right?
And that is something that you are working on the AUA task force, the workforce task force.
Right. We're really actively, the advocacy summit is coming up, and one of our main issues is a student loan forgiveness bill for urologists who practice in rural areas. So I'll put a little plug in there for that. It's interesting, though, women are more likely to say that they're forced to see certain genders of, more likely to see female patients, let's just put it out there, whether they want to or not. So although women are more likely to go into female pelvic medicine than male urologists, even women who don't specifically choose female urology feel like they're pigeonholed into seeing female patients. And there seems to be some data that if you're primarily seeing female patients, they're more time consuming and less likely to go to major inpatient surgeries. And so some of the pay gap may also be from societal expectations where women patients want women doctors, but those women patients may not actually reimburse as well as your prostate cancer patients. And so I don't know, we can encourage better referral patterns from our referring doctors to think less gender-based when you're referring patients to women urologists. But there is also a societal problem where the women patients want women doctors. So I'm not 100% sure how we fix that problem.
Right. The societal issue, I don't think we can turn that off overnight or anytime soon, but I hope that as more females enter the MD/DO realm when it comes to urology, hopefully that is slowly changing. Because I know there are male patients that I've seen who are uncomfortable. They tell me flat out, I don't feel comfortable having a woman performing a digital rectal examination, but that's the inherent population bias and societal bias. Now, when it comes to referral patterns, I even though I acknowledge that it is more difficult, it may be more difficult going this route, but I will say in 2020, in the world of internet and direct-to-consumer marketing, and look at what Jeff Bezos has done with Amazon, selling directly to consumer, cutting out the middleman. The internet has kind of eliminated that gap. There's nothing that prevents a woman or a human of any gender to go direct to consumer to advertise her practices or her practice or the things that she wants to do, whether that is BPH, stones, vasectomies, or whatever. There's nothing holding her back. But given the existing societal norms, it may take a little bit more effort. Now, something else you said, the referral patterns. I can see how in a large group, say a female urologist joins a large group, if you have an entrenched upper established men on top, that group may preferentially take the male patients while the new female urologist takes all the pelvic pain, bladder pain, interstitial cystitis, overactive bladder. And as you said, a lot of ladies want to see female urologists, and I'm just going to say it. Females tend to take a little bit longer because of whatever the empathy factor that is required. And I'm going to be killed for saying this, but sometimes I've thought this to myself. Sometimes I wish my wife would talk to me like a police dispatcher. Just tell me the facts and cut out all the detail, all the fluff, all the filler. But
right.
But that is, I'm gonna generalize. That tends to be the characteristic of a woman, of a female. Yeah. So they do tend to take a little bit longer, and I think female urologists who see a lot more women are probably going to be penalized when it comes to productivity in the fee-for-service model that we have.
We found that. So we found that the women urologists were spending more time with each patient, which correlated to seeing fewer patients per week. And our reimbursement system doesn't really account for that. I mean, yes, if you do more than 50% of the visit is on counseling, you can bill based on time instead of based on complexity. But ultimately, for the amount of extra time the women were spending with each patient, that's not translating into reimbursements. And so, it does account for some of that pay gap.
Yes. And in your study, a greater proportion of male earned more than $350K, which was the median, but there were no significant differences in self-reported weekly mean number of clinical hours, 43.1 versus 46.9 female to male. So that is not statistically significant. and also no significance between the non-clinical hours. Male reported doing more major inpatient procedures per month and seeing more patient visits per week. That's 78.4 versus 68.4. That's a lot. 10 more patient visits per week. And like you said, that could be the time demands for between male and female patients.
Correct.
Now, even though this is significant, or not significant statistically, I will translate that into something that's a little bit more tangible. Even though it is significant statistically, it is also significant financially. If you think for, let's see, the mean number of clinical hours, just the difference of 3 hours or so, 3.8 hours per week. If just assuming that you're seeing only 4 patients per hour, and a 99213, assume these are all 99213s, that translates to about $46,000 and 800 some odd change. That's not chump change. In addition, right, if you look at the number of patients seen more by men versus women, 10 patients per week, that translates to about $35,000 per year, assuming 99213, they're all level 3 patients. And when it comes to, and I've said this in the Thriving Urology Practice Facebook group numerous times, seeing patients based on time is not an efficient way when it comes to productivity, to see patients. So if you're billing based on time, you're going to be shortchanged.
Yeah. Well, and I also think, it gets down to what we talked about before about feeling comfortable with business. I think, and I'm a total idealist to a fault. And, when my husband and I were shopping for houses, I would walk into a house and be like, oh, but it feels so wonderful here. And he'd be like, but the electricity costs in this house are not going to make it a viable option, So medicine's a business. And I think we do a really poor job teaching our medical students and our trainees, our residents, that ultimately medicine is a business. And even in academic medicine, medicine is a business. And I think for people who started in academics a long time ago, there wasn't so much focus on the business aspects of medicine. But I know in my academic practice, we're in the Bronx, we were destroyed by COVID. We didn't work for 3 months. I mean, we did telemedicine, but no elective surgery for 3 months. And the hospital runs on elective surgery, let's face it. And so more than ever, we're being made aware of the business component of medicine. And I think that if we can do a better job of teaching all of our trainees, male and female, about the importance of, and this is something that you do very well, the importance of the business aspects of medicine so that we can make efficient decisions in terms of how we run our practices to maximize our ability to earn a living while still taking very good care of patients, and that's where we're failing our trainees.
I think that is applicable not just to females, but males. I mean, that's across the board, the poor training when it comes to how to run a medical practice. And I 100% agree with you. It is absolutely a business, and the CEOs and the HR people, they have, I mean, look at what happened during COVID. I mean, a lot of the employee physicians got pay cuts.
Yep.
But, the good thing is, hey, at least some of them have jobs. But I also have heard physicians just simply being laid off. And I know a urologist who was on track to being an employee. He was laid off. He was jobless. He had to look for locums jobs to support his family. So it is, it's a business. And so what is your school or your medical center doing to try to train the residents on how to be better business people, how to run a practice better? So so they don't have to be employees. I mean, first time in ever in history in 2016, more than 50% of physicians are now employees. So how do we change that, and what is Motefiore doing?
That's a good question. So we have a brand new program director in my institution.
How exciting.
Dr. Nithya Abraham is our new program director. She started July 1st. She's amazing. And we are trying to implement an I'm leading the way to implement what we call a life skills program for our residents. So it's not just about the business aspects of practice, but about all the things that our residents, they do a 5-year residency after 4 years of medical school. So they're almost 10 years behind their peers who didn't go to medical school in terms of having a normal life. So we try to teach them how to have a good relationship, how to plan for your family, how to buy a house, because trust me, in New York, not a lot of residents are buying houses.
Yeah.
It's just way too expensive. How to plan for retirement. What kind of insurance do you need? Like, how do you think about malpractice insurance when you're looking at a practice? So we are starting a program in our residency to try to work on some of these skills that our residents just haven't had an opportunity to explore because they're doing 80 hours a week in the hospital. And so that's our approach to this. Our faculty is 40% women, so I think we have a lot of great mentorship and role
Nice.
modeling. All of the women in our department have children, which is also good because we role model how to do work-life balance, right? Which is not an easy, we have similarly aged children, and it's certainly difficult. Who knows what we're going to do with our kids this fall, right? I mean, my kids are doing hybrid school. I don't know how I'm going to manage that yet. We'll cross that bridge when we come to it in a couple weeks. But, so we try to mentor for our residents what all those different things. We have a couple of older guys in our practice who are in their 70s still practicing.
Wow.
Who were private practice urologists and then joined our academic program late in their careers as a sort of part-time semi-retirement way of doing things. And so they have a lot of information about running a private practice to confer on our residents, which is really exciting for us. So I think, we have that nice balance of a lot of younger women and a lot of older guys who have been in private practice who know what that's all about too. So that's what we're trying to do.
Yeah, it sounds very admirable, and I hope you guys have a lot of success because God knows the residents certainly need it. I'm going to go
100%.
back to your urology practice article. It says that in the results section on unadjusted logistical regression analysis, men were more likely to earn more than 350,000 than women. However, in a fully adjusted model, gender was no longer statistically significantly associated with income, though the model could not exclude certainly a moderate effect size favoring the ability of men to earn more than women with the odds ratio of 1.59. Unfortunately, the p-value was 0.11. So if you do the fully adjusted model, gender was no longer statistically significant. What are your thoughts about that?
So I think there are a few things. I think some of which we've talked about and some of which we haven't. Not only are women more likely to choose academic practice, which we know pays less, they're more likely to choose pediatrics. They're more likely to choose female pelvic medicine. We know that being, an oncologist, even within the academic model, has a higher RVU than being a pediatric urologist. Let's face it, doing 5-year-olds circumcisions in the operating room is not a good way to make a living. And I'm a pediatric urologist, so I do plenty of those.
I call that a loss leader.
Yeah. But, all of the factors, women seeing more female patients, again, if you look at it as only what percentage of your patients are female, we don't have the data comparing female pelvic medicine doctors to females. We just didn't have enough, the numbers weren't high enough to make statistical analysis of that. But I do think that's a really important thing to look at. In pediatrics, there was a study, Barry Kogan did a study a few years ago where they looked at ABU data when pediatric urologists were sitting for their first subspecialty board, and they found that men had much higher work RVUs than women in pediatrics. There were some problems with the study because it was just based on ABU data, but so we know in certain fields even there is a gender difference. But I think of it more as women are choosing to practice differently from men. And that is probably leading to the pay gap, but we can't exclude gender bias. And I'll give you an example. Ben Breyer from UCSF was the first author on an article that came out, I think last year, looking at academic promotion. I was a co-author. And we found that women are promoted slower than men. So again, is that because they're having families and taking time away from work to have families? It could be. I know that certainly was my case. I got promoted to associate professor much slower than some of my colleagues with fewer children and stay at home, co-parents. But again, the difference between choice and being forced. The AUA census did show that women felt that they were discriminated against in terms of how patients were distributed in practices. Again, there could be referral bias there, or there could be, there's a great article in the Journal of General Internal Medicine that talked about the gendered expectations of the patients. The patients who were more likely to be labeled frustrating wanted women doctors, right? We listen better. It's very difficult to fix that perception.
Right.
And so maybe finding ways of working around that. There's been some talk about how to schedule patients to accommodate for the fact that certain patients are going to be more time consuming, and to build that into your schedule so that for pediatrics, you're avoiding dysfunction patients, even if they're a follow-up, might need a 30-minute follow-up visit, but a new circumcision patient might only need a 15-minute visit because that's going to be pretty quick. So while we normally would schedule a new patient as 30 minutes, there are ways to more intelligently schedule your day, and that may be even more important for female physicians because they're expected to see these quote unquote frustrating patients.
Well, in peds, I can think about ways to streamline that circumcision patient. So obviously, video printout resources provided to the parents, and by the you can probably cut that down to a 10-minute visit. Yep. If you are appropriately utilizing all your resources, the ancillary resources, having everyone else fill in all the stuff that you, the most expensive employee, doesn't need to fill out. And then all you have to do is concentrate on taking care of the patient. And
that's right.
And I will also note that you keep referring to inpatient surgeries being more generating more RVUs. If you're looking between just female and male pediatric urology, yes, of course. If you do more big cases, you're going to generate more revenue. But in real life, out in private practice, and I've said this for numerous years, the operating room is nothing but an expensive hobby.
Yep.
So in private practice, the more efficient you are in your clinic doing more procedures and seeing patients in your clinic, it's definitely generates a lot more RVUs than doing operations in the OR. So I just want to make sure everyone understands that and not just think, the more inpatient cases you do, the better.
Right. And I think that's, the census is biased in some ways towards academic urologists, right? And so in an academic urology practice where the office efficiency is usually not as good as in a private practice setting.
So how do we change that? I mean, it's always been that way. How do we change that? That's what I want to know.
A good question.
Because when I'm teaching these practice management coding courses, I had this group of academic urologists sitting on the front row, these gunners, and they seem frustrated because they feel like they can't make any changes in the infrastructure, in the way the patient flow, the workflow, how to make it more efficient. So I don't know what can be done.
Well, I know in our center, one of the challenges we have is that the physicians aren't in charge of hiring the ancillary staff, right? The institution is. And so, burnout is a passion of mine also. And, the lack of autonomy in academic practice not only promotes burnout, but promotes inefficiency because, we can't say, let's start clinic at 7 a.m. and do all the procedures before 9 a.m. when we start seeing our regular patients, because our nursing staff is union. So we can't ask them to come in at 7 a.m., right? We don't have that ability. So, there are a lot of issues in academics, depending on where you work. As we try to become more efficient, and we are working very hard at that as a department, I think our chairman is very business minded, and something I really appreciate about him.
That's great.
we're trying to figure out how to work with the unions to expand our ability to see patients in the clinic, that kind of thing. But it's a challenge for sure.
Yeah, no kidding. That's that would frustrate me. And I think if you understand the way you operate, what makes you happy, then you can seek careers or positions that may make you less frustrated. Because in that environment, I would not survive. I would be
So
so frustrated.
our bonus system is at least partly RVU based, right? And we have a different system for pediatrics and adult urology, because pediatric urologists in our setting, we don't even come close to what the adult urologists do in terms of RVUs. So I sat down and looked at the bonus structure in my practice, and I said, to get to the next bonus level, I would probably have to do 2 more operations a week, which would mean missing dinner with my children. Is it worth this amount of money after taxes, right?
Yes.
For me to not have dinner with my children on Monday nights?
Yeah.
And I said, maybe not. It may not be worth it. It may not be enough money for me to gun, as you so correctly said, for those extra RVUs, if it means making sacrifices at home. And that's a choice.
And referring back to what you said earlier, when you said that, our kids are similarly aged and you worry about school and how they're going to do the schooling, but you said that, how am I going to figure that out, right? So there's another issue right there. Most women take on much more of the parental role when it comes to kids. There's one huge bias right there. When you take on more parental roles, come on, 24 hours a day. That's the only thing that is limited. We all have 24 hours. When you are taking on more parental roles, more parental responsibilities, by default, you're not going to be able to contribute and perform more as a clinician, more clinical hours to be productive. So that's another societal norm bias, I guess you can call it.
Sure. And we know, we've in the literature of gender pay gaps, the mommy tax has,
huge.
And I think it's fair to say that I chose to be a parent. It was very important to me to be a parent. I chose to have 3 children. Nobody forced it on me, right? And I knew that there would be sacrifices. And for me, it was delayed promotion. I spent a lot of the early years of my career, as you did, I had 3 children in 4 years. And the early parts of my career were spent, as much on mommying as on career. And then as my kids got a little bit older, I was suddenly able to be more academically productive and get promoted. But I was okay. I'm still okay with that, but it's a choice. And I can't say society forced me to do this. I made a decision and it came with a cost.
Yeah. And certainly my wife made huge sacrifices she has multiple professional degrees, as a matter of fact, but she put all that on hold to raise our kids until they are more independent. So now she's just super awesome. She crafted a way for her to become productive, if you will, as a professional now that the kids are grown. But she made huge sacrifices. So that, as you said, mommy tax cannot be ignored. But I don't think how do we change that, right? You're biologically made to carry a child for 9 months. I guess you can always try to make men take on more of the parental responsibility by having paternity leave, I guess. I don't know.
Well, yeah, and we're actually looking at maternity and paternity leave during residency right now. That's my current project. So it should be pretty interesting. We're just starting to look at the data now. But, I've heard it said over and over again, and I think this is true, that the single most important career decision you're going to make is who you marry, right?
So this question has been asked. People have asked me, so John, how did you get to where you are? How are you so happy and successful? I tell them, number 1, don't buy stupid shit. And number 2, marry the right woman. So as from a male perspective.
Yeah.
watch your spending, because I think physicians and urologists especially, we certainly make enough money. It's how we squander our money, just like the government. How we squander our money, that's important. And secondly, who you marry is also very important. So those are some of the things. I mean, one, you can learn yourself. It's a self-determined type of thing. Who you marry, I think it's also that too, but sometimes you marry someone and you just don't quite know what can happen in the long run, right?
I agree with you 100%. And I came to responsible spending late. So I made all the mistakes, but I am now, right before I was on this call with you, I did check my budget app and make sure that everything was, taken care of. So I learned that probably later than you did, but the most important thing I've done in the last 5 years was budget neutral. So you're 100% right.
All right. Any parting words that you want to share with our audience?
I think we need to make sure that we're mentoring both male and female trainees in the business aspects of medicine, so that they can make informed decisions about what they want their practice to look like. And there's nothing wrong with women wanting to be employees or wanting to be in academics, as long as they're choosing that because they think that that's what's going to make them most happy. I don't think earning more money is necessarily the highest goal we should all have, but we should all make sure that we're getting paid fairly for the work that we do. And I think that that's the message we need to give people. I choose to get a less bonus to spend more time with my family, and I don't resent that at all. That's my choice. But it's an informed choice. And so we need to make sure that our trainees and even our early practice, maybe all practicing urologists, are making informed choices about what kind of practice they have, and understand what's available to them and what choices they can make if they want something different.
I agree with you. Mentorship and self-awareness are two key takeaway points for fulfillment and happiness, I guess.
In everything, and for financial stability. I mean, it's all of it, right?
Yes.
So we as a community need to do a better job of teaching about business. And that's on us.
Yeah. And I think that that is a pervasive problem just in medicine for all physicians. And that's why I'm seeing there's a huge upsurge of interest groups and Facebook groups and Reddit groups and everything like that on financial responsibility, especially financial information for physicians, especially because, like you said, we were locked away for many, many years in urology, 9-10 years, just studying and training. We lack a lot of those life skills.
Yeah, absolutely. Well, you're doing a really good job, though, with getting the message out there that, running a business is part of what makes urology practice enjoyable. There is enjoyment in that too. So.
Yes, definitely. Well, thank you so much, Dr. North, for coming on and sharing your message and sharing the data, and also the insight on what we could do to address some of this urology gender pay gap.
Excellent. Well, thank you so much for having me. I feel really fortunate. Thank you.
You're welcome. All right, folks, if you want to learn more about coding, billing, how to run your practice better, certainly feel free to join the Thriving Urology Practice Facebook group, where tomorrow, as a matter of fact, we are going to talk about the 2021 CMS Medicare changes that are coming up and how it will impact on your bottom line and your productivity. Until then, have a great day. Bye-bye.